Okay, thank you everybody for coming today. Today we have a presentation, and it's my honor to introduce our speaker today, Dr. Dan Davis Jr. He's CEO of Interactive Care Technologies, LLC, which develops telemedicine service for seniors, patients, and remote care sites. He was the Chief of Medicine and Director of Informatics at the Queens Medical Center here in Honolulu, and was also the physician champion for the Queens Epic Health Information Systems. He has a private practice as a general internist, and is also an associate professor of medicine at the John A. Burns School of Medicine. Without further ado, I'd like to welcome our guest speaker for today, Dr. Davis.
Thank you.
Thank you.
Well, thanks for asking me to present today. I'm going to talk about telemedicine and talk about two programs that are actually going on here in Hawaii, and hopefully provide some insights that we've gained about this that may be useful to you. Suppose you're on vacation on the North Shore, eating at a nice little cafe on the North Shore, eating lunch with some friends, and suddenly you drop the fork from your right hand. You attempt to say, "Excuse me," but the words come out a little bit garbled, and you cover for that. Your friends are talking, they're yakking, they've got a glass of wine, you know, it's vacation, and they don't really notice. You pick the fork back up, you go on with your meal, but you don't feel quite right. Maybe there's a little nausea. Your right hand feels a little bit clumsy, but you can still eat. You notice that your speech is just a little bit slurred or slow, and so you become the listener in the group. You don't talk because you're a little embarrassed about not being able to speak properly. 30 minutes goes by, the meal's coming to an end, and all of a sudden your symptoms come back. Your right hand's weak, you feel like you can't get the words out. You know what you want to say, but you can't get the words out. Everybody rises from the table to go out to the parking lot to your car, and you stumble to the right because your right leg is weak. And then everybody around the table knows there's something wrong. One of your mates there looks at you and sees that you're having problems that she recognizes as a stroke. The right side of your face is a little bit saggy. That's the F of fast. Your right arm is weak. That's the A. And you can't speak. That's the speech part, FAS. And then the T is time. Time is absolutely critical in getting the right kind of help to a person who's having an acute stroke. So she calls 911, and 10 minutes later the ambulance arrives. Now we're 40 minutes into this episode because it started 30 minutes before the meal ended. The EMTs take blood pressure, take a heart rate, maybe check some other vital signs. A heart monitor's connected. You're placed on a gurney, and the EMTs radio into their dispatch unit that they're going to be taking you to the emergency department. That takes about 15 minutes. Okay. The elapsed time so far is 55 minutes. It takes about 20 minutes to get you into the vehicle, drive to the emergency department, out of the vehicle, and into the emergency department, the local rural emergency department. Blood tests are drawn. You're taken directly to the CAT scanner. And back in the emergency department, by the time you get back, your stroke has actually gotten a lot worse. Now you can hardly raise your right arm off the bed. You can no longer hold your wife's hand with your right hand, and you can't speak at all. 90 minutes have elapsed since a small blood clot the size of a mustard seed has plugged up a critical artery in your brain. That's an acute stroke. You're losing about 2 million brain cells per minute in that process. And as they say, time is brain. Now, fortunately, in this small rural hospital, there's a full-time emergency physician there. Fortunately, they have a CAT scanner. and fortunately the CAT scan tech is there, and so they're able to get a CAT scan right away. But unfortunately, there's no neurologist in or near the hospital to help make the decision about using a clot-busting medicine called TPA. The emergency physician knows that TPA can help patients with acute strokes, but she also hesitates because she knows that the patients may sometimes bleed into the brain, and they do so because of the medication that she might order. So she hesitates, unsure what to do. Okay. Now it turns out that this scenario takes place on the North Shore of Boston, okay, or it might be the North Shore of Lake Pontchartrain near New Orleans, or it might be the North Shore of Clear Lake, California, or in many other communities across the U.S. where they have a robust telemedicine stroke network that bridges time and distance barriers between the patients who need the medical expertise and the medical experts. That notion of access to critical medical expertise over time and distance is the key insight, the key gift of telemedicine that we need to learn how to use. So then the scenario goes like this. The emergency doctor suspects that this is an acute stroke, notes that the brain CT scan, CAT scan looks normal. She phones the stroke hotline at the designated regional stroke center, which might be hundreds of miles away, describes her patient to the stroke specialist, one of whom's on call 24/7. Simultaneously, the nurse in that little rural emergency department turns on the telemedicine video camera that's situated there in the emergency room, brings it to the patient's bedside, and now an additional 2 minutes have elapsed. We have a cumulative of 90 minutes plus 2 minutes now, where that emergency physician has gained access to the medical expertise needed. Within 3 additional minutes, the stroke specialist is examining the patient through the telemedicine device, a high-definition video, and makes a recommendation immediately to give the clot-busting medicine, this medicine called TPA, and the patient receives the TPA within minutes. Total elapsed time in the scenario is now 95 minutes. 3 days later, that patient who was in the emergency room with almost a complete stroke, inability to speak, walks out of the hospital fully functional, full strength, normal speech, and pretty much back completely to normal. Okay? That is the kind of outcome that we want, and that's the kind of improvement in healthcare that happens when telemedicine is used in proper situations, and it works really well. The critical success factor with this is the notion that we're providing immediate access to medical expertise overcoming those time and distance barriers. And we need to think about opportunities to use that kind of telemedicine access in many other areas besides stroke. So why is time important in stroke management? And I'll tell you if we can get this thing to go to the next slide. Oh, there we go. Okay. Now hopefully it won't go further. So why is, do we have a pointer?
Yes.
Shall I point on the screen here? Okay.
Here's a pointer.
Okay, well here's
On the bottom left.
that guy. Okay, excellent. Now, why is time important in telestroke or in any kind of stroke management? Well, it's basically expressed in this slide that shows if you give the clot-busting medicine within the first 90 minutes since the onset of symptoms, out of 100 patients, almost 30 of them have significant benefit, and 1.5 patients have some adverse event. So the benefit-risk ratio in the first 90 minutes is extremely high. After 90 minutes, over the next 2 hours, we see that there's a little bit of drop-off in the benefit and a little bit of increase in the adverse effect, but still the benefit ratio is quite high. And the same is true if we go out to 270 minutes, about 4.5 hours. But the medicine has to be given within that time window, because after that, we start seeing that the benefit is actually lower than the risk in giving the medication. So timing is critical, and everything we can do to give that medication earlier, the better the outcome the patient will have. So giving TPA, though, is a tricky decision. Who should get it? People with small strokes, people with big strokes? Are there contraindications? The answer is yes. There's a whole lot of them. Is there a significant risk of bleeding? And the answer is yes. This medicine can cause very serious side effects. But fortunately, in this early time window, the benefits are far more common than the risks involved. And the problem with this is that small rural environments don't have the experience to be able to make the judgments about these cases as quickly as they need to. So again, the critical challenge is getting access to the medical expertise, getting that medical expertise to the patient when we need it. So what would happen if we were on the north shore of Oahu 2 years ago? Okay, well, the patient may or may not get the TPA that they need. And here are the statistics. This is a survey from the Hawaii Department of Health among 4 hospitals. None of them had a neurologist on site 24/7. Okay? Only 9 of them had access to any neurologist, and that was by telephone, a neurologist that was on staff. 2 of the hospitals had an acute stroke team, and 7 of the hospitals were staffed by emergency physicians who were willing to give TPA without neurologists. That means that the other 7 hospitals, even though they might know the statistics, were not willing to give TPA because they considered it to be too risky, or it was something that they hadn't done for 6 to 12 months. But there were sort of knowledge barriers or expertise barriers that got in the way. So the people of Hawaii even now have limited access to the state-of-the-art stroke management. So this lack of widespread stroke expertise impacts stroke management in Hawaii. And in fact, in 2010, there were over 3,000 patients who were discharged from Hawaii hospitals with a diagnosis of acute ischemic stroke, but less than 2% of them actually received the clot-busting medication. The national average is about 6% of stroke patients receive this clot-busting medicine. And in the best regional telemedicine stroke systems, about 20% receive the TPA. Now you might ask, well, why only 20% in the best systems? The main reason is because there's a delay in recognizing the symptoms of stroke. So in our stroke management programs, one of the key ingredients is educating the public about emergency symptoms of stroke so that we can get them into this, to the system and access the expertise in a timely fashion. Many strokes happen when patients are asleep, and so the time of the onset of the stroke we use as the last time the patient was known to be normal. So that means if the stroke happens during sleep, you really don't know. It's probably 8 hours before that they were known to be normal, in which case those patients are not candidates for TPA. So that's the reason for this low number. But yet you can see that in Hawaii that we're way below where we should be. So then the question is, what can we do to improve the access to this kind of expertise in order to get the care to our Hawaii stroke patients? Now, we're not the only community that has this problem. This is, I think, very illustrative. This is a very large hospital system in Colorado. And what you can see here is that about half the hospitals didn't give TPA at all. And all of these hospitals had at least one stroke patient admitted during the time period. And then some of them gave a lot, about a 16% administration rate. Okay? And so the challenge then is getting the expertise that these guys have over to these guys. And that same challenge happens here in Hawaii. So my belief, and the belief of Dr. Koenig and the others in the stroke program at Queens, is that the lower performing hospitals are the ones that simply do not have access, immediate access to the stroke expertise. So That's why we've started building the Hawaii Stroke Network, which is a telemedicine-based stroke consultation program. It's funded by a grant from the Department of Health through the Neurotrauma Special Fund. It's funded for 2 years and allows us to equip 7 spoke sites, those are the rural areas, with the hub, which is Queens. We call this a virtual hub and spoke because while the Queens consultants are the ones that do it, they don't really have to be at Queens. They can be at home, they can be at an office someplace, they can actually be on a cell phone or a wireless iPad. The system really doesn't care where they are as long as they've got access to broadband internet. But they're the ones with the expertise, and we can use the telestroke system to get the expertise out to the 7 spoke sites. Right now we have Molokai General, Waihiwa, and Hilo. We're going to be upgrading an older system that was put in place a few years ago that served as the pilot for this thing. So we're very excited about that. And it's actually being used, and there have been a number of patients that have already been treated with a system who have already been helped. One of our patients was a patient that came to Waihiwa with just exactly that story that I gave you. The guy had a dense right hemiparesis and walked out of the hospital 3 days later fully functional. So that was a real save. That makes a real difference to a real patient. This is just an example of what we're doing. The systems are actually pretty simple. This is the guts of the system. In the old days with what I call big iron telemedicine, you know, the big monitors and lots of equipment and wires and that kind of stuff, it was kind of intimidating, but with the newer systems with much less expensive and more highly functional technology, the systems are shrinking down, and one of these days we'll be able to do some of this stuff with something that looks like an iPhone. In fact, we're actually working on that kind of inexpensive device now. There's a simple touch tablet computer up here, and that provides the two-way communication. These are the folks over at Molokai General. They just got theirs installed in January. So it's real easy to use. There's only one button that turns the thing on and off. Doesn't require any technician involvement. And basically the way the system works is the scenario is that the remote spoke emergency physician decides this patient may be having a stroke. They call up the stroke hotline, speak to one of the stroke consultants, and while that conversation is going on, the nurse brings the stroke camera to the patient's bedside. The consultant, from wherever they happen to be, log into the website. The system picks up their image off of the camera, the little camera, USB camera or laptop camera that they're working with, and shows the clinician what they look like. The clinician has the option of turning that thing on and off. Dr. Cheryl Chang said she didn't want the patients in the remote site looking at her in her curlers at 11:30 on a Friday night. So the docs do have control over whether or not they show that. And then what they do is they click on one of the links to the cameras that the system knows that they have access to and that is live. And then it shows a very high quality video image. This is obviously a still of the video image, but a very high quality video image, and the doc can simply move their mouse to the area that they want to look at, click on it, and then the system brings up a very high quality enlarged image, and they can do remarkable exams with this image right here. If you wanted to, you could count the number of eyelashes or the number of hairs in my eyebrows there. Now, I apologize for the ugly picture there, but that's what I happen to have available that was easy to do. Maybe next time I'll have Dr. Koenig in there. But the notion is that with simply a browser and a mouse, you can do a remarkable kind of an examination in somebody that's many miles away, many hours away, within a matter of 2 or 3 minutes. And that's what we mean by using modern telemedicine to improve access to the medical expertise. So what I just described is the Hawaii Stroke Network, and the champion for this is Dr. Matt Koenig at Queens, and Matt visits all of the hospitals around the state, encouraging people to participate in this process. And we view this as a community resource that pretty much anybody can participate in that wants to play. And we like that notion of telemedicine community resource. Anybody that wants to help support it can join, and that diffuses the costs for all of the players in the system. So the insight, the stroke of insight about this is that we can use relatively inexpensive technology that's very easy to use to get medical expertise when we need it to the patient pretty much wherever they are, and that notion of technology-enabled access is something we should be thinking about in many different areas. So one could ask, what other areas are possible? So I'll describe another program that I've been involved in. And a few years ago, I worked with my colleagues, Dr. Nima Jacoby, Aldrich Ricaldi, and a case manager specialist, Corey Lee, registered nurse, to develop a program for medically fragile patients. These are the patients who are the sickest of the sick. They remain acutely ill for the rest of their lives. They spend an enormous amount of time in the hospital or nursing homes. And so we were looking for some way that we could take better care of these people. We couldn't find anything, so we said, well, we're smart people, let's invent our own care model and see what we can do with this. By way of background, there are a huge number of people in the U.S. that have one or more chronic medical conditions. 23% of Medicare beneficiaries, this thing is going automatically for some reason. 23% of Medicare beneficiaries have 5 or more chronic conditions. And within that subset, there are these medically fragile people. They're acutely ill forever. They have multiple complex problems. Many of them are on ventilators at home because they can't breathe by themselves. They have feeding tubes, IV lines, and these frequent and long hospitalizations. So the question is, how can we take better care of these people who are the sickest of the sick and by far and away the most expensive patients that we have in healthcare? Well, one answer is to create a technology-enabled care model that consists of one or more physicians, nursing staff with an Akamai case manager who's a clinical case manager, not someone who just does the paperwork, family and caregivers who are trained by the physician and the nursing staff to take care of that particular patient's specific problems. And then ancillary staff is needed, respiratory therapists, physical therapists, occupational therapists, and whatnot. And by putting all these together and linking them through technology that we call the video house call, we're able to provide virtually instant access to the expertise when these people need it. These are just some examples of the kinds of things that we can do with this. I didn't put the grossest pictures in here, but you can get some idea about the things that we can do. This is a patient who was homebound, developed a skin rash, and I'm on the live video camera watching them roll her over so I can see part of her skin. And it took about 1.5 minutes to 2 minutes to look at this, zoom in, and say, well, you know, I think that's a fungal dermatitis. There's no way to tell that over the telephone. Let's give her, try an antifungal cream, and we'll check 3 days later and see what it looks like. Give her the antifungal cream, 3 days later, the rash is 50% better. We know that we made the right diagnosis in about 3 minutes of time. I mean, literally. Compare that to the fact that you could never get a dermatologist to go out there. You'd rarely be able to get a clinician to go out to the home. And if you brought that patient into the medical office, what happened is that you'd use about 8 hours of 2 people's time getting the patient ready, packing up their ventilator, getting them in a specialized van, unpacking them, getting them up to the doctor's office, waiting for 45 minutes, see the doctor for 5 minutes, and then reverse the process and go home. It's a horribly expensive process, and it's dangerous for the patient. So, perfect example of how technology can turn a simple problem that would have been very complex in our conventional care model into a simple one. Same thing here, staff called and said, well, she's now getting this fungal rash around a tube that goes into her stomach. we were looking at it 2 minutes later, and it turns out that that looks more like just a little pressure from the flange, and we simply said, tape the tape 180 degrees away from where that red spot is, look to see if it's still there tomorrow, and sure enough, it went away. This is a patient where she was being cared for by a new staff member, little insecure. The woman was on a ventilator out in IAEA, and the caregiver calls up and says, she's hemorrhaging from her trach. I'm going to call 911. And so we said, what are the vital signs? They're normal. What's the oxygen level? Normal. What are the ventilator pressures? Normal, okay? And we said, okay, stop. Don't call 911. Show us what you're worried about. And so she showed us this trach sponge that has a little bit of spotting of blood on there. And we looked at the trach site and can tell that it's just a little bit of a trach granuloma, which all patients on ventilators get. And we could reassure that caregiver, no 911, stop the process, does not need to go to the emergency room. Now, had she gone to the emergency room, they probably would have found some reason to put her in the hospital. And then she gets in the hospital, and she winds up being there 2 days, 3 days, 5 days, gets a hospital-acquired infection and stays 20 days. Okay? Enormously expensive. And we can bring access to where the patient needs it within a very short period of time. So again, this idea of using telemedicine to bridge these access barriers is enormously important. And then just another example, same kind of trach granulomas, which we treat through the telemedicine system. We troubleshoot the ventilators. This is an individual who was ventilator dependent. She'd die without her ventilator. But we're able to troubleshoot problems when they come up. We can look at the ventilator, make adjustments on the ventilator, then look at the patient, listen to the patient, and do all of that stuff through this technology. So that's the notion of how we can use telemedicine, particularly the modern kind of telemedicine, in homes, care homes, nursing homes, pretty much any remote site, to take really good care of our patients. Now, what are the results of this? Well, we studied some of our early patients and presented a paper at the American Telemedicine Association a few years ago. And what we showed was that there was a dramatic drop in hospital days per year. In fact, this is highly statistically significant. We showed an 85% drop in hospital days using this technology-enabled care model. Now note, the technology is necessary, but it's not sufficient. The people are necessary, but it's not sufficient. It's a combination of technology and the caregivers that are organized into a care model for these particular folks. We also documented an 80% reduction in emergency visits. Now that's really important because these are scary patients, and if they show up in the emergency room, even if they really don't have to be admitted, very often they're admitted because if there isn't continuity with the caregivers who know them intimately and know what their home environment is, they always get put in the hospital. And if they get put in the hospital, then they get a complication from being in the hospital, and that winds up being enormously expensive. So the results of this particular study is an 80% reduction in hospital days. Actually, those numbers should be reversed. 85% reduction in hospital days, 80% reduction in emergency visits, 65% decrease in hospital admissions. One thing we noted is that if these patients do get hospitalized, they get hospitalized because the team says this person needs to be in the hospital. They put them in the hospital, they take care of the problem over a period of 1 or 2 days, and then they get them back home because they have a care environment that's actually better for the patient in the home than in the hospital. It's highly customized for that particular patient. So we're able to do a really good job with that, and I think this tech-enabled care model for medically fragile patients can be duplicated in with other populations in the state. Now, another thing that was interesting about this is that this notion of critical factor access to expertise. The docs that we had working with this typically would make about 4 face-to-face house calls on average per year with the medically fragile patients. On average, there are about 20 of these video house calls per year. 75% of those visits were sort of urgent or as needed type of visits. They were unplanned, and about 25% were actually planned. Okay? Now, there's no physician, there's no clinical nurse specialist or physician extender that can make that many contacts, face-to-face contacts with a patient by physically going to the home. There aren't enough hours in the day, and you don't have enough caregivers to do that. But because we're able to get to these patients within 2 or 3 minutes, the effort on the part of the clinician is really minimal. We're able to do this more often, and as a result, it's almost like continuous care of these people rather than them saving up a lot of their problems all at once and crashing every 3 or 4 months and having big problems. So that's a second area where the insight is that just like stroke, just like the medically fragile, if we use these technologies in a smart way, we can dramatically improve care and get expertise to the patient when they need it. So the bottom line insight here is that whenever you guys think about access issues, think about telemedicine, okay? Telemedicine today and moving into the future is not the kind of telemedicine that you may have seen 3 years, 5 years, or 10 years ago. We should not be using these giant boxes. Well, we can use those giant screens and boxes and real expensive equipment in certain circumstances. It's beautiful equipment. They're really nice to use, but they're real expensive. They're physically stuck in certain locations, and they usually require technical staff to maintain these. I'm talking about new web-based enabled technology that is much less expensive and where you don't need technicians to make these things run. Anybody that can run a mouse can run the kinds of things that we should be using. Now, this is a clever little picture. This is actually a magazine cover from April 1924, okay? And I believe this was actually before television was officially invented, which was around 1927. But the notion that there was a radio doctor, there's the doctor on the screen right there, who's looking at the patient's image, and there's the patient. The notion that we could do telemedicine has actually been around for almost 100 years. And it's just now that our technology has gotten good enough that we can begin to think about putting it into production in environments where there's enough value that these systems really ought to be paying for themselves. And so from what I would ask you to do as a planning agency, when you start worrying about access to care, start thinking about whether there's an opportunity for telemedicine. It may be the big stuff, it may be the cheap stuff, it may be something completely off the shelf, but think about telemedicine to try to bridge those gaps, and in doing so, I think we're going to dramatically improve the quality of care and lower costs. So, questions?
Yeah, I work for American Medical Response,
Mm-hmm.
and we do ambulance services in 36 states. And we're thinking about this all the time. In fact, we're beta testing in the pre-hospital setting out
Mm-hmm.
in ambulances. So, I mean, it's just almost right there.
Yeah,
People
yeah.
medics are probably taking pictures of the scene with their cell phone and keeping that to show a doc in the ER.
Yeah.
That this is what it looked like when they got there, but we're not sending that picture at the moment. But we are beta testing actual telemedicine sites, like in San Diego and some
Mhm.
places.
Yeah, it is technically very doable to send high-quality wireless video from an ambulance that's speeding down the street. Started at the scene, get consultation going.
Just to further that context, we also have beta models where we're going out and checking back on patients that are, like you said, they're not in the hospital, but they are at risk. Maybe the cardiac patients that are
Mhm.
discharged but
Mhm.
are still at risk. and they need to be checked up on. So we have models where we're looking at using the medics who are 24/7 and out and about.
Yeah, that's a great example. I'll give you another one. The timing for that stroke patient, about 95 minutes from onset of symptoms to the time they got their clotbuster medicine. There is a community that I'm aware of that has such a system set up so that the docs in the emergency room have already made the diagnosis of an acute stroke before the patient hits the door, all right? And what they do is the patient comes on the gurney through the doors of the emergency department, goes directly to CAT scan without stopping in the emergency room. The emergency personnel gather in the CAT scan, do the vital signs, draw the stat blood work. They get the CAT scan, and then by the time that patient gets back to the emergency room, they've already spiked the bottle of the thrombolytic agent, the TPA, and they got it hanging in an IV ready to go. Their time is 24 minutes. And again, patients with these strokes are losing about 2 million neurons a minute. And the faster you can get that medicine in the right patients, then the better off they're going to do. And I know that they're going to wind up with really good results with their stroke patients.
Going this way. And you said something earlier that we still haven't figured out a model that pays for the delivery of that.
Yeah.
And that seems to be one of the challenges.
Mm-hmm.
It's not there yet.
Yeah, you hit on probably the biggest barrier to providing better quality through telemedicine, and it really has to do with the financial arrangements. The difficulty that we've seen time and time again is the entity to which the financial benefits accrue doesn't pay for it. Okay, so for example, if we save an average of 20 hospital days per year or more for some of these medically fragile patients, that means the payer, whoever it happens to be, isn't shelling out that kind of money for that particular patient. That's a huge savings, okay? So what our job is to collect enough believable data to present to the payers, including Medicare, to say that, you know, you guys really ought to be funding this stuff. And there are many different models that one could use to do that if you could get the payers' interest in doing this. My personal feeling is that in a state like Hawaii, we have an opportunity to perhaps do that because, you know, we all talk to all of the decision makers for our Medicaid program and, you know, and our local payers. So it's important for us to understand that there are opportunities to do this, and the barrier is really figuring out how to fund it. Now, as the technology gets better and cheaper, you know, the costs of doing this go way down. So your sort of the benefit cost ratio then becomes a lot more compelling. The barriers that I see are, at least in the past, the technology has been a barrier, but I don't believe that's a barrier anymore. I think our technology's gotten really, really good. The second one has to do with the financial aspect, reimbursement or cost savings sharing or something like that. We've got to come up with models, and probably an experimental basis, you know, with different populations, so that we can do studies over short studies, 2 or 3 years, to really understand how to use it best in those populations. And then the third barrier is basically breaking the habits that have been established by a 100-year-old model of healthcare. And it's basically the doctor office, hospital-centric model of care. And we ought to be looking for opportunities to kind of flip that model on its head and truly make it patient-centric, so that we bring everything to where the patient is and where they need it. We're not going to be able to do that with everything, but I think we can do it with a lot of stuff. I mean, for example, with these patients, we do EKGs in the home, we draw labs in the home, we do chest x-rays and abdominal x-rays and ultrasounds in the home, okay? And so these patients, for whom it's very expensive and dangerous to move to the medical center, a lot of that stuff we wind up actually doing in the home environment. So I think we can get imaginative and better creative to, you know, to use these new technologies. A couple of other really interesting examples of things that we're probably going to start playing with within the next year. Some little cameras that for all purposes looks like an iPhone, okay, on a little device about this big that we think is going to cost less than $1,000. Okay, and think of the iPhone. I mean, that's a $600 device, but you know, we think we can get those things cheaper, smaller, easier to use in a logarithmic way. Well, once we do that, you know, we'll be able to put these out in a lot more homes for a lot less expense. Yes?
Well, I guess what I'm thinking, well, first of all, I should say I'm very supportive of the idea. I think keeping people out of the hospital is just a wonderful idea for all kinds of reasons, like you mentioned. And the part you didn't even mention was that all the tests that happen too when they go in the hospital.
Yeah.
And even if you kind of know what the person has, they're still going to do the CAT scan again and all those other things, even if you had one a little while ago. But I guess I'm thinking, why not use an iPhone for a lot of this? Or things that people already have in their homes.
Yeah.
And move more towards that model. So it's not just you're picking a few patients that you're going to give them this fancy new device, but we could all be using devices that are already in a lot of homes, and that physicians have too. You could be doing FaceTime, you know, with the doctor, in diagnosing the rashes or whatever, really without any cost, except I think figuring out the reimbursement model. And on that, I was thinking, you know, it seems like the accountable care organization would be a good place to fit this in.
That's right, because you eliminate the silos of financial benefit, I guess you'd say. It's kind of shared, so that if we do something good for patients in the outpatient environment, everybody benefits, and vice versa. Relative to the iPhone thing, I think we're getting there now. But think about this: if all you want to do is just talk to a person and see their facial expressions, iPhone, Skype, any of that stuff is fine as long as you trust the security and as long as you happen to get a good connection on that call. Okay. There are some technical issues, but the concept is really solid in doing that, and I think there's a lot we can do over those things. But what we found is that if you're taking care of these real serious medical problems, there are a lot of things that happen when you try to use a desktop computer with a camera on a wire, or a laptop computer that's got a camera embedded. And the joke that I use is, think about your partially demented grandma who has bleeding from her bottom someplace, okay? Are you going to be able to convince her to stick the laptop between her legs up close enough for the doctor to be able to see where that blood's coming from? Now, that's kind of a gross example, but it shoves home the notion that there are certain things that you just can't do with a laptop. Okay, well, what about an iPhone? Well, you can do a lot of stuff with an iPhone, but you don't have the zoom capabilities that are necessary. And what we found is that if someone in the room is holding the iPhone and the doctor's looking at it through a remote device, the person holding the iPhone winds up looking at the patient, and then the camera drifts off. Okay, and then the doc has to say, oh, move it back, you know, move it a little bit further. No, I want to see this thing or that thing. Okay, and so what happens is you wind up giving all these sort of movie directions to the person holding the camera, and that is distracting for everybody.
Would that be the same with these other devices?
No, it's not. And the reason is because these devices, you bring them to the bedside, you stick them on a bedside table or something like that, and it just sits there, and then the doc has control over the pan, tilt, and zoom of the camera. The cameras don't move except under control of the doc. So there's no wiggle of the arm. You know, the person holding the camera doesn't wind up inadvertently causing it to drift up or down or right or left or that sort of thing. So it actually, the pan, tilt, zoom capabilities work really well. I think within the next few years, we'll probably have either through something like an iPhone or, you know, any of the other devices, applications that may allow us to do that, and those cameras get better and better. This is an area where the technology, the devices have to perform to a certain level, but we really ought to be planning systems that, as much as we can, are really kind of device independent, because those devices are going to get, you know, smaller and cheaper and better every few months, actually. You were going to ask a question.
That was my question, actually. It was whether the consumer devices that people are carrying with them are good enough or not. And
they're good enough for some things, and I think they will continue to get better. And so where we can use those kinds of devices, we really should. Great.
Any other questions?
Okay, well, thank you very much. So my challenge to you is when you think that you've got an access problem, think telemedicine, okay? And I would be more than happy to come back and noodle with you about different kinds of telemedicine and what might be applicable, what might not be. Be happy to talk to you about some of the people issues that are involved in this, because these are always more people issues than they are technology issues.
I just have one more comment on that. I mean, I think that's always what I think of when they're talking about barriers to access. So, there's been some statewide studies saying we need this many more cardiologists on Molokai or whatever. And I'm thinking, you're never going to be able to support a neurologist on Molokai or Lanai.
Right.
I mean, it's just not going to happen.
Right.
And so I think, what they should be thinking is how can we give patients access without flying everybody over?
Well, right now, because of Hawaii Stroke Network, the people on Molokai and the people who go to Wahiawa General have better stroke coverage than people at many of the other area hospitals. Because within 2 or 3 minutes, they're talking to they're talking to world experts about stroke. These systems don't care about time. They don't care about distance. Okay, great, good. Invite me back the next time you want to talk about some of those issues.